Joining us now is our newsmaker and a very special exclusive guest, Professor Adrian Hill, vaccinologist and director of the Jenner Institute and professor of human genetics at Oxford University, that's driving the Oxford AstraZeneca vaccine. First of all, Professor Hill, is this today a day to smile? Can we say that we possibly have another important tool to halt the COVID-19 pandemic in the Oxford AstraZeneca vaccine based on these interim trials?
Yes, I think we can. The really good news is the world now has 3 vaccines that are reporting high efficacy on large numbers of subjects in very large trials with excellent safety data, and then a couple of additional findings as a bonus. And those 2 in this trial are firstly seeing that there's even higher protection against severe COVID and hospitalization. In fact, we had no cases of hospitalization in our vaccinated subjects in this huge trial. And secondly, an original finding looking at the asymptomatic infected individuals, those who were infected but were well. We see a substantial reduction in those subject cases on vaccination.
So not a single of the various patients that you had during the trial was hospitalized, am I correct?
Who had been vaccinated,
who
yes.
Had been vaccinated.
Some were who were given the control, which was not a vaccination for COVID.
Right.
So yes, that's an encouraging sign.
You know, one of the top line headlines this morning was that the overall result showed that the Oxford vaccine offered 70% protection. Now, when I compare that to a Pfizer, Moderna, which claim more than 90% protection, explain that to our viewers. Why is it 70% in the case of the Oxford vaccine and 90% in the case of the other vaccines?
So what we did was we had such large numbers in the trial, we had the opportunity to compare the Oxford vaccine tested in 2 different dosing regimes. So in one of those, we gave everybody the full dose of vaccine. In the other group, we gave people half a dose followed by the full dose. And what was really interesting is that regimen, which is pretty new, everyone else is using the same dose twice, gave 90% efficacy. In contrast to 60% in the other regime, if you average them out, it's 70%. But of course, we're allowed to go forward with the better regimen, which is exactly what we are going to do. So yes, it's about 90% is what we're seeing with the regime that we're going to take forward.
So Professor Hill, what therefore it means is that the Oxford vaccine matches the efficacy of other vaccines by simply slightly tweaking its dose. That increases efficacy from 70 to 90%. If I take half a dose and then take the full dose, that double dose gets 90% efficacy. Am I correct?
That's what we saw. Yes, exactly.
In a sense, therefore, are we looking at a 2-dose regimen vaccine as far as the Oxford AstraZeneca vaccine is concerned?
Yes, indeed. And all the 3 vaccines that have reported good efficacy so far use 2 doses. Very hard to get this to work with 1 dose. We had to look at that. The immune responses weren't high enough in our view. So the other advantage, of course, of this low-dose, high-dose regimen is that you get more vaccine for every amount that you manufacture, because you're now getting twice as many vaccinees with the first dose as you were going to if you gave them a full dose.
One of the other, of course, big advantages that the Oxford vaccine is said to have is that you don't have the same stringent cold chain requirement that Moderna and Pfizer requires. Pfizer requires to be stored at -76, Moderna at -20. Presumably, Oxford will be at regular refrigerator temperatures.
Yes, we will. Like most vaccines that we use every day, everywhere in the world, our vaccine is stable at 4 degrees. It's only these very new RNA vaccines where so far people have not been able to stabilize them. Maybe that will happen someday, but at the moment, yes, you need freezers and sometimes deep freeze.
And the costs, Professor Hill, there are various numbers doing the rounds. I'm told it could be priced at around £3 in Britain, much less than Pfizer and Moderna again. Has that been worked out or has that been left for a later date?
No, that was agreed last April between the university when we were licensing to AstraZeneca, and AstraZeneca sub-licensed to the Serum Institute of India. And the provision that goes through that agreement is that for high-income countries, during the pandemic, the price will be around about $3 per dose. Not £3, $3.
$3 per dose.
Per dose. Whether you're in the United States or you're in Burkina Faso in Africa, the same price. After the pandemic is over, that price limit remains in low and middle income countries, but not in rich countries. So there's an opportunity for the company to make money then after the pandemic. But for the moment, our priority is not that. Our priority is ending this pandemic.
You know, all of this is very good news that's coming out. You have in Serum Institute of India, your India partner, and the big question everyone is asking in India, when do you expect to actually have the vaccine ready first for emergency use? Serum Institute of India seem to suggest possibly by January. Is that realistic? Are you looking to go to the UK regulator as early as next month?
We're 23rd of November. We won't get to the UK regulator by the end of November. That's a week away. But certainly soon after that, we would hope to file for what's called emergency use authorization. And we will do that in the UK. We will do that in the European Medicines Agency for continental Europe. And hopefully we can work with Serum and with the Drug Controller General of India, DCGI, to see how quickly an application can be made for Indian use as well.
So
yes,
would I be right in saying,
happen.
given the positive results that have come today, that January for emergency use in India, given that Serum has the capacity to produce at a very high level millions of doses, is realistic?
I think it depends on two things: how quickly we can get all the information to the regulator to review, and how quickly the regulators can review it. And I think both of those activities will proceed very quickly in this case. So yes, early January would be the target.
So the first stage, of course, as you said, is emergency use, which presumably is for care home resident staff, followed by healthcare workers, and then the plan is to work down age groups. So has a time plan been made where, let's say, 6 months, 9 months from now, we could be in a position to actually have it available to millions of people?
Well, I think that's for each country to decide. I've seen a plan very recently from the Department of Health in the UK, aiming to vaccinate most people by April. But of course, the more vulnerable, the more elderly before that. The task in India is much greater, of course, because the population is so much larger. But you do have the world's largest vaccine manufacturing companies. So that's a big plus for India.
You know, the question that a number of people are asking, Professor Hill, normally it takes years for vaccine development. You managed to fast forward and crunch this process. We're now looking, as you said, possibly by next month, emergency use vaccine. What has changed? What explains the dramatic success, if I may use the word, of the efforts put in by you and others in vaccine development this time?
Yes, I teach our students that it takes 10 years to develop a vaccine. We're on month 10 at the moment. This has been different in many ways. We have had enormous help from all sorts of quarters, from the funders who have provided money very rapidly, from the regulators who've been available day and night to look at amendments to our protocols, to the support of international agencies who have raised funding to pay for these doses that we would now hope will be manufactured and distributed, and being allowed to overlap the phases of clinical trials. So normally we have to finish phase 1, get all the details from that trial in maybe 100 people before going on to the next 1,000 people. They were overlapping those applications this time. So I think we have learned about some ways in which we can accelerate vaccine development in general. But, you know, the world has to decide at many levels that this is a priority for trials to go so extraordinarily quickly.
Just wanted a quick clarification, Professor Hill, that Dr. Hill, that this two vaccine regimen, will the second vaccine be about a month after the first one? Is that the way you see the two dosages working?
Yes, we've looked at 1 month, 2 months, and 3 months. They're all about the same. So 1 month interval would be sensible because you want the second dose as quickly as possible.
Are you already, if I may ask in conclusion, are you all already celebrating, or should I say any celebrations given the regulatory approvals required, given the need to ensure complete safety, are premature at this stage? Is it a day to celebrate?
We are not at the finish line yet, but we have overcome the final fence on the way. So now that we have efficacy data, a lot of what we have to do is administrative and a lot of paperwork creation and perfection and submission. And that's going to be very busy over the next few weeks. But yeah, by the end of the year, we should have some celebration.
And may I ask how many people have actually been involved in this exercise? How many people at Oxford have been involved in this entire exercise to bring this all together?
So narrowly, 270 people have been working really hard night and day in many cases. They're pretty exhausted having got this far. But there are hundreds more. There are 19 trial sites just in the UK for the UK trial. Brazil has been absolutely amazing. They started after us and they have caught up. They have vaccinated over 10,000 people. Large trial going on in South Africa and in Kenya. They have started now. Of course, Serum have their own trial in India, and there's a trial of 40,000 people gearing up. And I think they told me this morning they had vaccinated 10,000 in the United States. So everything is still very much happening.
This is terrific news, Professor Hill. I want to say it's early Christmas, and as a former Oxonian, I feel a deep sense of pride in what you and your fellow vaccinologists may well have achieved. I think you have every reason to smile, really, Professor. There's good news.
Thank you for being another one of our supporters. We've had a lot of support. I appreciate it.
Thank you so much for sharing that news with us. The AstraZeneca Oxford University vaccine could be with emergency use in Britain by December, possibly in India with Serum Institute by January. That is terrific news coming in there from Oxford. The big challenge, of course, will remain distribution, Professor Hill. I guess that's going to be the other big challenge. Am I correct?
Two big challenges: manufacturing enough and distributing it quickly. Those are the next challenges.
Right. Well, we'll wait for those challenges at a later date. For now, the good news is coming in from your trials of the vaccine you've developed. Thanks very much, Professor Hill, for taking the time off. Thank you.
Thank you.
Terrific news coming in there from the Oxford vaccine, just the kind of news to lift the spirits at a time when, unfortunately, India is facing what many are calling a new COVID wave. There's been a dramatic increase in COVID cases in 6 states in the last couple of weeks. Just take a look at what is happening in the country at the moment. Active COVID cases in Delhi up to 40,000 in 2012. That's a rise of about 17.7% from 34,000 at the start of the month. Himachal Pradesh, another state where winter is set in, 7,032 active cases, again a rise of 136.4% from 2,974 cases at the start of the month. Rajasthan, 23,190, sudden spurt of about 52% in the last 2 weeks from 15,255 active cases. Madhya Pradesh, 11,765 cases now, from a rise of about 37.8% from 8,538 earlier. Haryana, 20,344, a rise of 61%, another worrying point. And Punjab also experiencing about a 60.3% rise in cases. It now has 6,724 cases rise. So if you look at North and Central India, where winter is setting in, where the festive season has just gone on, several states here witnessing a spurt in COVID cases. The national capital, unfortunately, leading the way. And it appears clearly that this now, at the moment at least, is a North Indian wave, with several states here now imposing a night curfew in the worst hit districts. In a moment, we'll be joined by 2 of the country's top doctors to explain what needs to be done. But just take a look at this story first.
Desperate times call for desperate measures. The Delhi government, faced with an alarming rise in coronavirus-related deaths, has started fining mask violators 2,000 rupees. It also shut down 2 markets for flouting social distancing norms. The markets were later unsealed, but the warning doesn't seem to have worked. The markets were crowded as soon as they reopened.
We are confident that despite the increasing number of cases, Delhi would be able to handle it well because we do have the medical infrastructure. Within the last week has increased 400 ICU beds to ensure, and these are in different Delhi government hospitals in different parts of the city.
Cases are rising not just in Delhi, entire North India bracing for a jump after Diwali celebrations. Rajasthan, Gujarat, Madhya Pradesh and Himachal Pradesh have imposed night curfew in worst affected districts.
7 बजे से जितने भी दुकान हैं, व्यापारिक प्रतिष्ठान हैं, उनको बंद रखा जाएगा और 8 बजे से सारे एग्जम्प्टेड कैटेगरी के अलावा बाकी सारे लोग हैं वो अपने घरों में रहें, दुकान सब बंद रहें और जो उल्लंघन करेगा उनके खिलाफ कार्रवाई किया जाएगा.
The new wave of COVID infections has the other states worried. Maharashtra, which has seen a drop in COVID cases after being the pandemic epicenter for months, is taking no chances. It has made mandatory for passengers taking flights and trains from Delhi, Rajasthan, Gujarat and Goa to carry COVID-negative RT-PCR certificates. Next 1 week will be crucial for North India as COVID cases, as a result of crowding during the festival season, could emerge now. State governments are now scurrying to implement the COVID safety norms with an iron hand. But one wonders if the crackdown has come a few weeks too late. Bureau Report, India Today.
And joined by two of the country's top doctors as we look at this second wave of COVID, Dr. Rajdeep Sardesai, the All India Institute of Medical Sciences Director, and Dr. Hemant Thakkar, Mumbai's leading consultant physician. Appreciate both of you joining us. Dr. Sardesai, to you first. Do you see this as a second wave or a third wave in a form in North India, not just Delhi, but across the northern states? And is it linked directly to the onset of winter and the festive season?
The wave, you could call it the second or third wave, but there's definitely been a spike in the number of cases. And it's possibly related to 3 factors. One is, of course, the festive season, which has just got over, and we saw that there was really very little COVID-appropriate behavior. And we had crowds, and we know that if you have crowds like this and you have people who are not wearing masks or not having physical distancing, any of these crowded areas can become a super spreading events, and that can lead to a spike in number of cases. Second is, we know that respiratory viruses tend to increase, or the cases tend to increase during the winter months, and that is what we're seeing in North India. And this happens every year when we look at data from H1N1 or swine flu, that it tends to peak during this time of the year. And as has already been pointed out, that pollution also tends to play a role, and the combination of air pollution, the fall in temperature, and the lack of COVID-appropriate behavior over the last few days has led to this spike in cases as far as North and Central India is concerned.
Right. So much more localized to these states. It's not an all-India phenomenon. Could I say that pretty safely?
So if we were to call it an all-India phenomenon, then we would see a big spike in the number of cases that we are seeing on a national basis. The number of cases at a national level have actually continued to be around less than 50,000 per day. That level has been consistent, and that hasn't shown a spike. What we're seeing is an increase in certain localized areas, especially cities where there has been a lot of crowding because of the festive season. And therefore, I think this does continue to be, as of now, relatively more in certain states rather than being all over the country.
You know, Dr. Thakkar, you're there in Bombay. Are we seeing a major distinction, therefore, between, let's say, a Mumbai and a Delhi? That where Mumbai, there seems to be, at least in total number of cases and even in positivity rate, some kind of a control coming in. Delhi and other parts of North India are experiencing this spike. Are you also suggesting perhaps that this is much more localized now? It's no longer a pan-India phenomenon?
So I like the adjective that you used at first. To me, it appears like a North Indian wave. And while in Mumbai, we are holding our breaths and we are sitting at the cusp, because today is about just a week since the Diwali celebrations have completed. I want to wait for the next 5-6 days. But I can certainly say in the last 3 days, there has been a small up in the number of cases. I'm not trying to scare anybody, but if we had nothing during the run-up to Diwali, we have about a 10 to 12% spike. Of course, we have beds available and everything is there. But you know the old Indian saying that if you do what you did, you will get what you got. Or for the North Indians, I will say, Jaisi karni, vaisi bharni. If you don't have social distancing and the markets are blaring with shopping and there's celebration, meeting, hugging, greeting, everything going on, they have to pay the price. And I'm happy that the Maharashtra government is trying to Lakshman Rekha the city and the state, because up to now, Mumbai and Maharashtra in the first and second wave was the epicenter. And we do not want our state to fall into the same category. Having said that, we are still one India, and it will take only 2 flights and 2 super spreaders to bring everything all over the country. So I am again holding my breath and folding my hands to say that let's keep the country free, let's exercise discipline. The rule of the law has to prevail. Whatever you find them, you have to find them immediately, and you have to exercise discipline, without which we are in trouble.
Therefore, I come to you, Dr. Guleria. Has this spike been created also by a fourth factor that perhaps needs to be looked at, which is the lack of civic discipline? The government has said 2,000 rupees fines for those not wearing masks. When our reporters went on the ground, they found mixed responses to this even among the public. The enforcement was not as effective as they would have liked to see. Is that part of the problem, you think? We've been using this word earlier, a sense of COVID fatigue, or is it just civic irresponsibility, Dr. Guleria? Do you believe wearing masks and strict enforcement of that will in some way control the problem in the next few weeks?
So I think it's a mixture of both, but I would say that we, as far as our civic responsibility is concerned, we as citizens have not been as responsible as we should be. And this is not only because of the pandemic, but if you go back, we would see that we have areas which we say are no smoking areas. Hospitals are no smoking areas. Yet you will find people hiding in a corner and having a puff. Similarly, you will find a lot of such behavior going on in our country with the attitude ki ye sab chalta hai type of. So we have to have responsibility as far as citizens are concerned. And when it comes to cough etiquettes, it's very important, not only from the point of view of preventing the pandemic, but even for diseases like tuberculosis and other respiratory infections. Unfortunately, we as a society have not been able to do that. And this is one of the prices that we're having to pay. If you look at countries in our neighborhood, Southeast Asia, then they have not had a spike despite economy opening up, because they have continued to have appropriate behavior. The citizens have been disciplined. They have continued to maintain physical distancing and wearing masks. And you can look at countries like Cambodia, Vietnam, Taiwan, where the number of cases continue to be low. Not because they have some magic medicine available. It's just that they have good civic sense among the citizens, and that has really made a huge difference.
I just want to ask you also, as a follow-up to that, Dr. Guleria, a number of North Indian states now are introducing night curfew, that you have curfew from 9 p.m. to 6 a.m. Is that really working? I mean, do you believe night curfew is really a solution?
So it's not an absolute solution. I think what is happening is that a lot of states are trying to balance out the economy and the growth and, let's say, livelihood along with what they can do to a limited extent. And I think one of the options is to try and see how much they can limit people interacting with each other, especially when we talk of late night parties and get-togethers. And a lot of events like that have started happening because this is the season when people tend to have get-togethers, marriage and other things. So possibly this is one way of trying to curtail that. But I think this is just one small step in a lot of things that need to be done.
We talk about super spreaders, Dr. Thakkar, you use that word. And among the concerns, I know in Maharashtra also that a few bureaucrats told me is, they've opened up religious places of worship under political pressure, one of them told me. And you've got the wedding season now coming. The festive season is over, the wedding season is going to peak. Does that worry you, large weddings, even though the rule is of not having more than 50 people? there will be those who will perhaps try and get around that rule. Weddings and religious places, are these two potential super spreaders?
Absolutely. You know, India is a land of jugaad. Everybody finds a way out. Those 50 can become 100 at a wedding function, and they weave themselves into it. As far as religious worship is concerned, I still believe in my old thinking that my God lives in my heart. So I want to be careful by not going and congregating in such places, which under the name of religion, anything can happen. So when we are sitting at this crossroads where things can tilt into a very catastrophic situation, we have to be careful. At this stage, I want to point out about the use of these new fashionable masks. Every time a patient with his relative walks into my clinic, they have a very small black or red or brown mask with a little tilt to cover the nose. And they keep pulling it down and the nose gets exposed. When I tell them to cover the nose, the cheek gets exposed. So the fashion is to wear matching masks which are small and which really don't do the job.
You know, you're
It is
embarrassing
that
me.
little
You're
tight-
embarrassing me, doctor, because look at what I'm wearing. If you look at this mask of mine, my worry is that my nose doesn't get covered. Are you saying that my mask must cover my nose at all costs?
I am happy I'm not in your studio and I am at my house, because if you don't cover your nose with a nicely fitting either an aluminum clip or a nice little bend and cover it, because see how much struggle you're going through and down your nose is open again.
Yeah.
So you must have a long mask. It doesn't hurt to go from the chin to over the nose. Safety and caution rather than matching and perfection of outfit. A mask is a necessity, not a decorative outfit.
Okay.
And we have people wearing masks for the sake of masks.
I think
So
you've
my
hit me.
message today-
You've hit me where it hurts. You've taught me a lesson today, because I've been among those who perhaps have not followed that protocol as rigorously as I should have. You're saying ensure that the mask has an aluminium clip at the top so that your nose is fully covered. Am I correct?
And there is a little pressure. So the space is not potential between the nose and the mask. Because when you tell the patient, naak ko dhak lo, he pulls it up, his chin gets exposed, his chin he covers, the nose gets exposed. So use a mask as a protective agent. It's useless if you wear a gun that has no bullets. You
Okay.
have to be careful, and you're going to have Christmas parties, New Year parties, and a lot of youngsters at night are going out because they know the policing is less at night, and they're sitting on the bumpers of cars and enjoying the cool climate without masks. So the night curfew is something that I do like.
Okay. You like the idea of a night curfew. You've told us about the mask. You know, Dr. Guleria, one of the other concerns, and you've looked at this very closely, and you've told us this before, a lot of people have lung diseases, have asthma in particular, and they are particularly vulnerable. Do you believe that there is are you finding certain age groups being more prone in this second wave or spike, as we call it, because of their precondition, because of their susceptibility to possibly pollution, for example?
So what we're finding this time is that, and this is slightly different from the spike that we saw a few months ago, that the number of patients that we have in our hospital are those who have much more severe illness, either because of comorbidities or with severity of COVID-19. And that's possibly because of multiple factors. One is, like you rightly said, that this is the time of the year when people with chronic respiratory diseases, whether it be COPD, asthma, they tend to get worse. And with COVID-19, it really is a double whammy and creates a lot of problem for them. Also, what has happened is a lot of mild patients now do go in for home isolation, and therefore we are not admitting them. So although the number of patients that are still significant in our hospital, we have more than 550 patients admitted in our hospital, the type of patients that we saw, say, in June, July, when we had the first peak, we were admitting a lot of mild patients as per the guidelines and the policy then. Now, many of them are being followed up to teleconsultations. We talk to them morning, evening. They monitor their saturation, their temperature, and if need be, they get their blood test done. Only those who are sick or who have comorbidities or saturation is falling do we admit into our hospital. But though these patients are quite sick, and therefore now the strain or the stress on the healthcare workers has become much more, because when you have to manage these sick patients, it needs more intensive treatment, whether it's nebulization, whether it's high flow oxygen, whether it's chest physiotherapy. And doing all of this in a COVID ward is quite challenging as far as managing these patients are concerned. So we are seeing now patients with more severe illness. And I think the change in temperature and increasing levels of air pollution is actually making matters worse.
So just to clarify, if you've got mild infections, doctor, or mild symptoms, you're saying stay at home, follow the regimen at home. That's better than going to hospital, because already hospitals are getting crowded. We've got a shortage of COVID beds. Would you strongly suggest any mild symptoms, stay at home, don't need to get admitted to hospital? Am I correct?
So 2 or 3 things are very important here. One is that you should have facilities for home isolation. When we're saying stay at home, as per the guidelines, you should have a separate room with an attached toilet and a caregiver who can provide you care. You should be in touch with a regular your physician. It could be a GP, so that he can monitor you day in and day out. And if you deteriorate, then he can have you shifted to the hospital. So home isolation has to be properly monitored. You should have the facility at home. If there are 10 people living in one room, then you have to go to a COVID care center rather than isolate yourself at home. Okay. But what we're trying to say is that if you are stable, if you're relatively young, you're not in the high risk category, then it may be better if you stay at home. It will help, because psychologically also it helps you. There are people who feel much better if they stay at home, take their medicine at home, and just monitor themselves and improve while they're at home. Right. Being inside the hospital in an isolated environment where you're not close to your family and friends, and you're seeing people wearing PPEs coming regularly to see you, can cause a lot of stress and strain as far as individuals are concerned. Therefore, I think if you can, and you fall into a category where home isolation is something that is practical for you, then one should consider home isolation, but always stay in touch with your physician, so that in case in that small minority where you have some complication or saturation falls, you can immediately be shifted to the hospital.
Well, we have one of India's top physicians with us, Dr. Thakkar. What are you advising your patients? Are you going through the same routine in terms of the medication that you were a few months ago? Is there anything different that you're following at the moment for most of your patients?
No, I think I agree with Dr. Guleria. We are encouraging people to get treated at home. But the one line I would like to add here is, don't give up in a week, because we are seeing the virus lying low and timid for 5 to 6 days. And on the 7th or 8th day, when everybody feels the worst is over, that's when the cytokine problem happens. So we're seeing people coming in on 7th or 8th day with problems. So I would say, even if you're being treated at home, go the full hog and wait for 11 days before you're saying that you're out of the woods. Coming to your question of treatment, I would disagree with WHO, because WHO is like a pendulum these days. It's either to the left or to the right. And I'm sure my colleague Dr. Guleria would agree that even if somebody in the WHO was to get a bad COVID, they would still take remdesivir. And we are using the traditional standard line of treatment. Each physician with his local expertise is trying to innovate only for the benefit of the patient.
I want to also ask you this, because as the festive season comes, it's also now the holiday season year end. People want to go and get a break somewhere or the other. You want to go to, let's say, a Goa or some place which is nice and warm. Want to know, is that advisable, Dr. Thakkar, that people should travel November, December, particularly December, closer to New Year? Or would you say this year, forget New Year, forget Christmas?
Well, if I was going to be more Catholic than the Pope, I would certainly say try and avoid traveling, because traveling means crowded airports. Crowded airports, after that, means crowded hotels. and crowded places. Unless you're going to a desolate place, you're driving there, there are lesser people there, you're not going to go into restaurants and groups, you'll be safer that way. I don't want to be a killjoy or an antisocial element, but the fact remains that you decrease your chances or you minimize your chances if you don't go to crowded airports where people make a beeline for the seats, and if you don't go to holiday resorts which are crowded.
Okay.
But then human nature is human nature. We have to temper a little of good with the bad. But like I said, if you do what you did, you will get what you got. We have to be careful.
Jaisi karni, vaisi bharni. That's the message that Dr. Guleria and Dr. Thakkar in a way are sending. I hope that this message resonates from India's two top doctors. As always, Dr. Guleria, Dr. Thakkar, it's a pleasure talking to you because you give us a sense of confidence in what really needs to be done by our viewers. Thank you both very much once again for joining me as these cases spike across the country.